This program is made possible by a grant from the Kugelman Foundation. This original WSRE presentation is made possible by viewers like you. Thank you.
Hi everyone, I'm Bill Harrell and welcome to Inside Healthcare. Our topic tonight is treating the uninsured. In the United States, it's been estimated that over 40 million people live without health insurance. Here in Florida, the total is 3.7 million, or about 25% of Florida's population. In Escambia County, the number is 76,000, and in Santa Rosa, there are 18,000 people uninsured. Now, who are the uninsured, and what is their impact on our healthcare system? And more importantly, what are the local services available to them? We'll answer those questions tonight at this town hall meeting located at the Gene and Paul Amos Performance Studio on the campus of Pensacola Junior College. Joining us tonight for this town hall meeting is Dr. David Conkle. He's a volunteer medical director of Our Lady of Angels St. Joseph's Medical Clinic. Welcome, Dr. Conkle.
Thank you, Bill.
Also joining us is Fred Cornett, the administrator of Good Samaritan Clinic in Santa Rosa County. Welcome, Fred.
Thank you, Bill.
Also with us is Dr. Donna Jacoby, a clinical associate professor at the FSU College of Medicine branch in Pensacola. Welcome, Dr. Jacoby.
Thanks.
Also with us is Dr. John Lanza, the director of the Escambia County Health Department. Welcome, Dr. Lanza.
Hi, Bill.
And joining us is Dr. Gary Pablo, the medical director of the Emergency Trauma Center at Sacred Heart Hospital.
Hi, Bill.
Welcome. And with us is David Schoberg, the Vice President of Planning for Baptist Healthcare.
Thanks,
Welcome,
Bill.
David. And finally, Dr. George Smith, the Medical Director of Escambia Community Clinics. Appreciate everybody being with us tonight. David, I wanted to talk about that figure 40 million, because we're hearing a lot in the healthcare debate about the high number of people without insurance. If we start to break down a figure like 40 million, you know, how does it break down? Who are the people that represent that 40 million?
The estimate for actually at the end of 2008 was 46, a little over 46 million. And if you take a look at that number, standing by itself can be a little deceptive. About 80% of people who are uninsured have jobs, and they work, and for some reason they don't have coverage in the workplace, whether it's a small employer or they elect not to have it, but about 80% of them work. Of that number, out of the 46 million, more than 13 million are in the age range from 19 to 30 years old. So there are a mix of people in there who, some of them don't have incomes high enough to purchase insurance from their employers, but some of them choose not to. I mean, there are a good number of people who choose not to do it, and at that age, a lot of people think, I can do without it for a while. About 20% of that figure, which is close to 9 million people, are either legal or undocumented, not citizens of the United States.
So is it fair to say that it may not be as large a figure, that some people may have access to Medicaid, some people may just not participate in their insurance plan at work? In other words, it's not that they're unable to get it, it's just they haven't elected to.
Certainly there are a percentage of that figure that elect not to have health insurance.
All right, so where do the figures come from? You know, this is one of the things, you know, we keep hearing 40,000, maybe in the future 54 million. You know, I mean, where are these figures? Where do they come from?
Most of them come from the United States Census Bureau and counts there, and they keep up with it that way. And it's estimated probably 13 to 14 million, including a large number of children, which also included in that number, probably are eligible for other health care programs that are out there, like Medicaid.
All right, let's look at the local numbers. That's something you're very familiar with. 76,000 in Escambia County. I understand that may even be growing.
Yeah, because of the economy and the rise in the unemployment rate in the last year, our most current estimate is about 80,000 people. So in Escambia County, that's 1 in 4. The state rate's 1 in 5, but we have had a higher rate here because of where we are economically. So we're at about 1 in 4 people in this county.
And do you keep up with Santa Rosa County, the 18,000?
The latest figure I had for Santa Rosa County is about 20,000 people. So it's not as high a percentage, but it's still, that's a significant number. So that's 100,000 people in the 2-county area.
Okay, a significant number, wouldn't you say?
Significant number.
Well, Dr. Jacoby, for years you practiced with West Florida Regional Medical Center. You did primary care work. Why is it important, or what are the advantages of someone having a good primary care physician?
Well, I think you want to have one person who knows all of you. We're a world of specialists these days, and it's okay to seek out that expertise when you have a particular problem, but somebody needs to be the coordinator that keeps track of all the pieces and parts, who knows you, hopefully knows something about your family, your values, and can help you coordinate your care.
Would that be one of the problems of people who don't have health insurance, that they're not able to have a primary care physician, and they maybe go into an episodic type of situation where they see a doctor but don't see him on a regular basis?
I think people without health insurance tend to access care when they have to, and that usually means an emergency room or urgent center where they're seeing someone episodically, not someone who's going to follow up even with that concern at the moment. And it's very hard to access primary care these days, even if you have good insurance. We really have a shortage in our community, I think, of access to primary care for the well-insured. It's a field that has a lot of demands and not a lot of rewards in the way of finances compared to some of the other subspecialties. And these days, I think the average indebtedness of medical students coming out of medical school is in the $120,000 to $160,000. And it's kind of hard to entice them into those lower paying specialties when they face such debt.
Well, I wanted to talk a little bit about kind of the broad healthcare system. Does it tend to favor treatment over prevention? In other words, when we look at where the dollars go, where they're spent in healthcare, do they seem to be on the back end instead of the front end?
I think very much so. Most of the fee schedules, payments are based on treatment procedures, not on preventive measures. There is some debate about whether pure prevention is cost-effective dollar for dollar, but it just somehow seems perverse that we tend to encourage people to get sick before they get care, because there are ways to help people minimize the effect of their chronic conditions rather than waiting for them to get in more serious trouble.
We've talked about access, and Dr. Pablo, access is certainly an issue when we talk about the uninsured. Don't the emergency rooms across the nation provide the most common point of access for the uninsured?
I would agree with that, and they're certainly the last stop for the uninsured when they're critically ill or acutely ill. Our uninsured population here reflects the numbers that Mr. Schoberg was saying, that we're basically about 25 to 27% of our patients are uninsured that come in the emergency department at Sacred Heart.
Well, we had a chance to talk with Tara Jocelyn. She's a patient care manager at Sacred Heart's Emergency Trauma Center, and she kind of talked a little bit about the patients coming in and where they're treated and that type of thing. And so why don't we roll this tape and take a look at the Sacred Heart Emergency Trauma Center.
Okay.
The reason that our Emergency Trauma Center is designed is to take care of those patients that are truly having a life-threatening illness or injury. Those type patients are patients that are having a heart attack, a stroke, a patient that might have been involved in a motor vehicle collision that's possibly has multiple fractures, broken bones, possibly internal injuries, needing emergency services. Otherwise, they'll be life-threatening and they need those services quickly. Those are the types of patients that our Emergency Trauma Center is designed to take care of. Because of the resources that we have, the way the facility is designed, the skill level of the nursing staff and the physicians that we have here to care for those patients, we are here truly to care for the life-threatening injuries. Our patients that walk in the front entrance of our emergency department are greeted by a registered nurse who does a triage process. Our triage process is a way to categorize patients based on what their complaints are, how their presenting vital signs look, and basically how the patient looks overall. The nurse does a head-to-toe ABC kind of assessment to determine where is best suited for the patient to be treated in our emergency department. We do see some patients that don't technically meet emergency criteria. Most of those patients are seen in our emergency care unit, which was opened about 2 years ago as an extension of our emergency department. So we could care for the patients that were having to wait longer, extended times, in a little more quicker treatment area for them, because sometimes the challenge for those patients is they don't understand why they're having to wait so long, and that's basically because they are not a true emergency, and the patients that are true emergencies are being seen first. It's certainly a challenge at times because patients don't always recognize that they are not the sickest patient truly in the department, and they are having to wait for those a bed to become available. We start our process in triage with those patients. We'll order lab work to expedite their care, so when they do get to a bed, the physician can jump in very quickly, have the lab results that were needed, and take care of the patient as quick as possible. It can be very challenging to explain to folks why they're waiting, but we do the best that we can, and we try to accommodate them and make them as comfortable as we can while they are waiting. We are very fortunate in our department to have a social worker on staff 7 days a week that can also assist with these patients that we feel are not true emergencies, kind of talking with them and discussing why did you choose the emergency department as your care facility today. There are other options in the community, and try to get that education piece out there so that the community knows that they don't have to come and sit and wait in the emergency department, that there are other options for them outside of the emergency department. Our volumes have increased tremendously over the last year. We typically see about 90,000 patients in a given year's time. That is including our pediatric population as well. So we've seen a big growth in our department. Certainly we're here for the community to take care of patients and their needs. I hope that we can get the education piece to the community to hopefully help them understand that there are other options other than the emergency room, but certainly we are here to help in any way that we can, and we will. We do not turn any patients away, and our goal is to take care of the patient.
All right, Dr. Pablo, there it is. People come to the emergency room. It's supposed to be used for life-threatening problems. They come in, you have something called emergency care. You can put them over there. There are wait times and things like that. But let's talk about the cost of an emergency room visit. You know, is it the best place to go?
It's certainly not the best place to go for things that could be handled in a lower level of acuity kind of a place, like an urgent care center, a doctor's office, et cetera. You have to, for example, at Sacred Heart, as Tara said in that little piece, we see over 90,000 patients a year. We have to have board-certified emergency physicians on duty. That requires a certain level of compensation to cover for them. You have to have enough nurses and support and ancillary support to manage the patients that come in that we see. A bad trauma case, for example, could tie up an emergency room physician, a trauma surgeon, a physician assistant on the trauma team, 2 or 3 nurses in the emergency department. You've got an x-ray tech, maybe 2 x-ray techs, a respiratory therapist. It's a big team when somebody like that comes in. And that's a lot of resources that have to be paid for and managed. And so the cost of those kind of things are spread out across the entire cost of the department. And if you come into the emergency department, take a simple thing like the flu. You see somebody in our department that comes in with the flu, and even if we don't do a lot of lab work and stuff, just our basic minimum cost that the facility has to charge in order for those patients to be seen is significantly higher than what you're going to pay in a physician's office or an urgent care center. And for whatever that problem is, it escalates from there. And, you know, I'd like to kind of clarify something about people coming there that really aren't emergencies and stuff. An emergency is someone's opinion. It's the patient's opinion that they have an emergency. So if you've got a mother that's maybe, this is her first baby, and it's 3 o'clock in the morning, and this kid's screaming, and she can't figure out what's wrong, from her perspective, that's an emergency. Now, if that mother happens to be you know, the wife of somebody with really good insurance, and they come in there and they make their copay, and you know, that system works really well. But sometimes that mother is somebody that doesn't have insurance. But from their perspective, the mothers both feel the same way about that baby, and we don't know until after the fact, is this really an emergency or not? So it's not cost effective, but at the same time, it is a safety net for the community. So when we hear, I tend to get a little frustrated when I hear things like, well, there's people out there that don't get health care. Everybody gets health care, but some people aren't getting it effectively or efficiently or in a cost-effective manner. But we're there for the community, and that's not just true of Sacred Heart, that's true of Baptist, that's true of the emergency departments all across the state and all across the country.
Well, let me give you a scenario here. There's a young person who's working at a grocery store on Scenic Highway, and he is offered health insurance by the grocery store he works for. But he is 27 years old, and he wants to buy a power saw. And so he doesn't want to spend his money on health insurance. He wants to buy a power saw. So he saves up enough money, gets that power saw, and one Sunday afternoon he's working with that power saw, and all of a sudden it goes into his leg and it goes deep. And it starts blood's everywhere, and all of a sudden, you know, he gets rushed to the emergency room, and, you know, the treatment is given and that type of thing. And, you know, all of a sudden you've got somebody with no insurance, but yet, you know, he's working, he's made that, you know, decision not to have health insurance. I guess my question is, and I'm going to really give this one to you, Dave, because you know the numbers, you know, who pays for all that? Who pays for these people that come in, you know, with these injuries? Is it the cost shifted to all the other people that pay their health insurance premiums?
In part. I mean, not-for-profit hospitals, you know, it's their duty and their job to allocate a good portion of what they earn each year to the uninsured. There are some offsetting dollars. The uninsured themselves pay a small amount on their medical bills. People, you know, feel like they should, and so some of them do manage to pay a small amount. Medicaid pays hospitals who do an extraordinary amount or more than average of care for the uninsured. They pay in what they call a disproportionate share rate. So they get a higher rate from Medicaid to help offset that. And all healthcare organizations negotiate with private insurers, and usually that negotiated rate includes some offset for costs of the uninsured. So it's really a combination of things. The hospitals absorb some of that themselves, and there are offsets from other insurers, other payers.
We're going to get into the mandate question later on. Should everybody be required to have health insurance? I'm not going to ask that now. We're going to ask Dr. Smith a question about, you know, if someone visits Escambia Community Clinics, what type of medical problems do they typically have at Escambia Community Clinics?
Well, we have two sections to our clinic. We have appointments where we have patients who are who have that as their medical home, and there they have a provider for their chronic illnesses, diabetes, hypertension, asthma. We take care of all of those problems, including preventive health as well. We also have the urgent care, or what we're calling open access, where patients can, if they have acute illnesses, sore throats, we do work, school physicals, sports physicals. We do some minor trauma, suturing of lacerations, treatment of minor injuries. So there are two facets to our clinic.
Now, you recently became a federally funded health center. And tell us what are the advantages there and what's involved. In other words, it was a grant, and tell us how important that is.
Well, we could start off with that. The first thing with becoming a federally funded community health center is that we do get a federal grant. And we are coming to the end of our grant cycle. We've had this grant for 3 years, and we got $1.2 million from the federal government to increase access and certainly take care of patients who are medically underserved, who are uninsured and medically needy. In addition, with that, we there are certain mandates that come along with having a federal grant. We have a community board made up of 50% of users of the clinic. In addition, we also have access to what's called 340B pricing, which allows us to purchase medications at really significantly discounted rates, which we can then pass on to our patients. We haven't implemented that yet, but that's a benefit of being a federally funded community health center.
Wanted to make sure people understand the sliding scale concept. By being part of this federal grant, you actually have to charge someone when they come in. You just can't give them free care. What is a sliding scale, and why is that important to somebody out there maybe who doesn't have insurance?
Well, that's correct. Let's say our cost for a particular visit may be $100. We counsel patients based on their monthly income, and they are charged a sliding fee scale. The minimum in our case is $5, and then it might be 25% of the bill. Some pay 40%, 50%, and if your income is above a certain level, then it's going to be 100% of the bill. Now that's important to keep us going so that we can continue to take care of those who are uninsured and to increase services and increase access to care.
Very good. Dr. Lanza, the Escambia County Health Department offers a lot of services to people in our area, but I wanted to talk about We Care, the We Care program, because what exactly is it designed to do? In other words, there's some people out there that have gone through and say they need an operation. They need a hernia operation or probably breast removal or something like that, and they don't have the money. Is the We Care program designed to help them?
Well, the We Care program was set up after some state legislation was passed back in the early 90s. And the Escambia County Medical Society Foundation worked with the Escambia County Health Department and the Board of County Commissioners of Escambia County to set up a We Care program. And what we have in our county, at least, is a volunteer specialty physician referral program, such that primary care physicians, family medicine docs, for example, see a patient, see that they have an issue, cardiology issue, some surgery-related issue, and then if they are Escambia County residents, they've been residents for at least, Escambia County, Florida residents, and then residents for at least 6 months, then they can be referred to the health department who manages the program for the Medical Society Foundation. And we've been doing that since 1992. We, at any particular year, manage around 500 or so individuals who are referred into us. And last year, we provided about $6.8 million in-kind care that was provided by the 190 plus physicians, specialty physicians that are signed up with our program, and the 3 hospitals in Escambia County that provide laboratory services, x-ray services, and sometimes operating room services.
And how does someone apply for the We Care program?
Well, they don't apply for the We Care program. They get referred into the We Care program by a primary care physician. That's the only way to get into it. So you have to be seen by a primary care physician. And our #1 referral source is Dr. Smith.
Okay.
Over there in Escambia Community Clinics, as well as my health department staff and primary care physicians in the community.
Well, Dr. Conkle, you're a volunteer medical director with a faith-based clinic. And we had a chance to visit St. Joseph's Medical Clinic recently. And let's roll that tape, because I think people are going to have an eye-opening experience to what it's like really on the front lines of healthcare.
Yeah, I sure do.
They come from all walks of life, each with a different story to tell. But they have this in common.
All right, well, let's get your temperature, blood pressure, and pulse.
They're sick. They don't have health insurance, and they need help. Their safety net is Our Lady of Angels St. Joseph Medical Clinic.
We have a lot of homeless people. We have, of course, a situation now where we have people that have just lost their insurance with their jobs and need a physician to write their meds.
One lady had her own business, and due to cancer, she lost her business. And she wasn't able to pay for her health insurance anymore, and she was tearful, she was apologetic for coming to us, but we're here to serve.
Yeah, if it wasn't for it, it's definitely, I would probably be dead, because it is a life or death situation for me personally. you know, because of my diabetes and being out of control. You die. You know, at my age, you just, you know, because there's no one there. I mean, there's no place for me to go.
Located in downtown Pensacola, St. Joseph's is a free clinic that treats the poor and those without health insurance.
I have diabetes, and they help me with controlling it. And before, when I was trying to pay for my medication, it was like $300 a month. My sugars were like up in the 500-600s, and that was because I wasn't able to actually get my medication like I needed to. But now that I've been able to be stable, it's down and it's coming under control.
The clinic opened in 2002. It is supported by donations and staffed by volunteers.
We have wonderful nurses, doctors, social workers, administrative people, and all of us here are volunteers. So unlike some other places, when people donate and a certain part goes to administrative costs, every nickel donated here goes to patient care.
It treats 40 to 50 patients each day it's open. Last year, it saw 4,800 patients, an increase of more than 70% from the previous year. When you enter the clinic, it may look like chaos, but it works like a fine-tuned machine that operates on Tuesdays, Wednesdays, and Thursdays to provide healthcare services to those in need. Rising healthcare costs and unemployment have forced more and more people to try to survive without health insurance.
And I'll bring you those medicines out to the waiting room if you want to wait there.
The clinic provides these people with medical services and prescription drugs,
which involves helping people that are indigent, that are financially eligible, in getting medications that usually are very expensive. The companies will give free medicine to individuals that meet their eligibility requirements, and those requirements are usually fairly liberal.
Operating in a small house in about 1,600 square feet of space, the volunteers use 4 examination rooms to see the patients. In a small bathroom, crutches are stacked in a shower because space is so sparse.
And we only have 4 rooms, 4 exam rooms. And on one day of the week, we have volunteer dentists who are in one of our 4 rooms. So only 3 to see patients, and that gets us backed up where we could be here sometimes for many hours trying to get through the backlog and make sure everyone is seen before we close.
The good news is that Impact 100 awarded a grant of $102,800 to expand the facility.
We'll be able to expand our exam rooms from 4 to 8. A lot of these people, I don't know whether they told you, often wait 2 or 3 hours to be seen. None of them seem to complain. As you can see, our volunteers, they're constantly waiting on rooms, so we feel like when we expand from 4 exam rooms to 8 exam rooms, it'll really increase our efficiency. And we're going to add a little over 800 square feet just onto the back of the building.
St. Joseph Medical Clinic offers hope to those it serves and is truly appreciated by those often neglected.
These people here, they treat you like they were sent from heaven, because you never see a frowning face. You always greet it with a smile, and they take care of you like you paid for it, and it's free.
And we in the community have to reach out and help those who for one reason or another are less fortunate and really need our assistance. So this is a place where love is made visible and caring is made visible, and you can't be in a better place than that.
They're kind of like, more brotherly than, you know, going to a physician. They actually care, you know, they actually care, and they shake your hand, and they pat you on the back. They're not afraid of you, you know, and they how you doing, and how's everything going, and you know, they're really, really concerned. And then if you're not doing good on your diet, they'll, you know, because they really, it's love is what it boils down to, that they actually love these people and care about these people.
This has been a wonderful experience, I think, for all of us, including the patients. Certainly, I think, enjoy coming here. I think if you talk to our volunteers, we get an awful lot out of being here. A lot of gratification in helping others and taking care of people that obviously need medical care. Just with the way things are today, really can't afford health insurance, or it provides them with a service which in turn we feel very gratified and be able to give it to them.
Dr. Conkle, certainly a very nice tape about your organization.
Sort of says it all, doesn't it?
The thing is, I guess on Tuesdays, Wednesdays, and Thursdays, people walk in, they get free health care, and they also have volunteers that treat them, and then many times they can go out with prescriptions, medications, right? And tell us a little bit about how the organization works.
We, when we initially started, Bill, we thought we would primarily take care of acute problems, and much like I'm sure physicians have found that start a new practice, our practice has really grown to where probably maybe a third, 30 to 40% of our patients now have acute problems. Over 50% of our patients are patients with chronic illnesses we follow on a continuing basis. They are required to be financially screened because our physicians are all retired, and therefore we rely on a state program called Sovereign Immunity, which provides us with malpractice insurance to see these people if they financially qualify. Until this year, that was 150% of the federal poverty level. This year, it's 200%. We have social workers who deal with these people's problems and provide them access to all of the programs that are available to them in the community. We have, as you can see, wonderful nurses. We have a very active drug assistance program, which has with our population of patients going up is becoming more and more important, because providing these people with free medication has become quite costly. Last month, our drug bill at the clinic was over $8,000. We are, as your piece showed, we survive through the goodwill and generosity of our community. We have many people who provide us with private donations. We have many businesses in town which will help us. The hospitals certainly help us with x-rays through their uncompensated care programs. We Care provides specialty care when these patients need that. We have a very cost-effective contract with LabCorp, which is a private lab company in this town, it's an unbelievable contract. It was made in 2002 by one of our early physicians, and has not changed since that time as far as costs are concerned. So we've been very blessed through the help of our community to be able to take care of an increasingly large number of people. As the piece said, last year we saw 4,800 people, and the year before we saw about 2,500 or 2,600 people. This year we'll probably see somewhere over 6,000 people at our clinic.
Once again, thanks for the work that you do. Fred Cornett, you are part of the Good Samaritan Clinic in Santa Rosa County. Now, your clinic is located down Highway 98 in the Tiger Point area. And tell us a little bit about the people you treat, and if you have a prescription program.
We treat people that have no medical insurance and that make less than 150% of the poverty level and live in Santa Rosa County. We provide the medications through a small pharmacy. If we don't have that, we use Walmart, which is a $4 drug or $10 for 3 months. We also send them to Public for 8 antibiotics, which are free. And we have a very large and active patient assistance program, where last year I think we provided about $600,000 worth of medications for the people that were going to be on the medications for the long term.
Now, you told me one time that 70% of your patients are women.
That's correct.
Why is that?
Well, most of them are working ladies that have children. They work in low-paying jobs. If they are sick and they don't go to work a couple of days, they're looking for another job. And so that's the kind of patient that we get there. We serve a lot of patients that keep coming back. As long as they're qualified, we see them again. But we also try our best to keep them out of the emergency room. Every year, I think I don't know, 1,300 to 1,500 people we keep out of the emergency room.
Well, very good. Well, we're going to take a question from someone in our audience right now, Dave Brewster. He's from Avalon Beach, Florida. And Dave, why don't you go ahead and stand up? And his question, he's an insurance broker, by the way, and sometimes he meets people who just don't qualify for insurance. In other words, pre-existing conditions, things like that. And go ahead and, what is your question?
Well, when I have someone sitting across from the table from me, and they're looking at me with hope in their eyes, they don't qualify for insurance, they're not dual eligible, and in some cases not even Medicaid. Is there a centralized location, a coordinator, or someone that I can guide them to? We've seen the beautiful services they're offered this evening, and God bless you all for that. But I have a hard time when I can't look in someone's eyes and say, there's nothing I can personally do for you. Is there someone else or a coordinated effort where I could say, call this person and they can help them find the health care they need in their area?
Okay, anybody want to tackle that first?
I can't tell you the telephone number, but you can certainly call our clinic for those people.
You can certainly call ours, and it's not 850-934-0064.
You can certainly call ours too. It's 436-4630 for the Escambia Community Clinics.
And when patients present to the hospitals, usually there are staff in the hospital that try to determine if they're qualified for Medicaid or other programs.
And for the health departments, it sort of depends on what exactly they're looking for. We have in Escambia a small primary care program. We do accept Medicaid. We do have a dental program, but it's mainly children. We do a lot of work with children, maternal child health care issues in Escambia. The We Care program perhaps would be a specialty referral program. It sort of depends on exactly what they need.
I think the free clinics, and I participate in one that's in the central part of the county called Health and Hope, that operates the same way these others do. Those are clearly aimed for people that are financially indigent, not just medically indigent. And I know my source is send them to Escambia Community Clinics because they do work both counties and they are trying to build services toward the north end as well. And they take insurance down to no pay at all. They take the whole spectrum. So I think for me that's the central resource I use.
We'll see everyone regardless of their ability to pay. As we mentioned, we have financial counselors and our minimum, the minimum fee is $5. The feeling is that when patients pay something, they buy into their care and they're more likely to be compliant.
You know, we're really very fortunate in this community because the hospitals go above and beyond trying to address these problems. Escambia Community Clinics is really a role model clinic for almost any other place in the state who has a federally funded clinic. It does an excellent job. And our faith-based clinics are doing a fantastic job out there. And the problem is, this problem is bigger than all of us put together.
One of the other advantages that we have in our clinic, in our county rather, is with the 3 great hospitals that we have here and the Navy Hospital. But we also have a pediatric and OBGYN residency programs here located at Sacred Heart, the FSU only FSU residency programs in existence. And for years and years, they have provided a lot of free care to the children and women in our community, and we are blessed to have that hospital here in Escambia County. I'm a pediatrician. I did my pediatric residency there, and I'm very familiar with the great things that they do, that those 2 programs do in our community, and most people don't really realize that they're there.
And John, just to add to that, because of our federal grant, we've been able to add a certified midwife and we started prenatal care in collaboration with the Sacred Heart OB residency program at Seton. And so we're able to get those patients from the moment we discover that they're pregnant and start their prenatal care. And as you well know from the Healthy People 2010 statistics, or infant mortality is a lot higher than other counties in the state. So I think that will make an impact on those statistics.
All right, well, thank you very much. Karen Pope has a question, and Karen is really going back to the emergency room, Dr. Pablo, and she's talking about what happens when someone comes in and is treated in an emergency room, but they need follow-up care. And if doctors won't see them and they're uninsured, where do they go? Karen, go ahead.
Okay, it's kind of a follow-up to the question that you addressed a little while ago about episodic treatment. And if you go to an emergency room and you have no insurance and then you do need follow-up care, do the instructions or the advice surrounding that happen at the emergency rooms for these folks so they know how to get to one of the clinics for follow-up, and do the clinics help coordinate that with the emergency room and their staffing?
We work with all the clinics, the free clinics like St. Joseph's. We work with Escambia Community Clinic. We work with the residency programs, the OB/GYN residency programs, and Seton Center Clinic, and then the pediatric clinic. And our records in the emergency department are electronic, and we are tied electronically too. So for example, if somebody comes in and they don't have a primary care physician, and it's clear they're going to need follow-up, and it's clear that Dr. Smith's clinic is somebody that can help them, then what we'll do is we'll actually refer them to the clinic. And our system is such that I just choose Escambia Community Clinic on the discharge instructions. They get the contact information, and that record's automatically sent to them. Sacred Heart's bylaws require that any physician who's on staff there has an obligation to see a patient in follow-up at least one time. Now, they don't have to see him for free, and working out the cost between the patient who receives the care and what he's going to pay for the physician that renders the care, that's between those two individuals. And sometimes they'll get them into weak care, and sometimes our social service people can help. But they are obligated, and they live up to that obligation to see that patient at least once in follow-up. So if they require a subspecialist, they go to our subspecialist on call. If they can be taken care of by a generalist, then we'll send them to usually Escambia Community Clinic or Santa Rosa Community Clinic. And a lot of the folks we see are actually already kind of halfway established with Health and Hope Clinic or Good Samaritan or one of the other free clinics, and we'll refer them back to them.
Well, that's very good. Go ahead.
Gulf Breeze Hospital also refers those kind of patients to us, and if they're our patient and they give them a prescription, we fill it for them. If they're not a patient, we screen them to see if they can become a patient.
Very good. Dr. Jacoby, we've been talking about primary care physicians and trying to have that continuity of care and that type of thing. And I want to talk about the future of the labor force, meaning that the people that are going to take care of people in the future. And we're starting to see maybe if more and more people get into the healthcare system, if legislation is passed, will there be enough primary care doctors to treat all these people who are currently uninsured? You work, with a medical school. You're training physicians. Are there going to be enough?
I think with or without health care reform, we're facing shortages in the workforce, and not just for physicians, but nursing, social work, therapy, pharmacy, you name it in the healthcare disciplines. We're looking at a shortage. We were talking before the program started about the age of Florida's physicians. The majority are in the older age group, and a survey done a couple of years ago said quite a significant percentage were considering either cutting back or leaving the workforce altogether within the next 5 years. And that was really before Obama and health reform made the news day in and day out. There are things hidden in the 1,000 to 2,000 page bills that are aimed at trying to help with workforce issues, establishing some councils that work on recruitment, retaining, training, funding to help reduce the indebtedness of students in training, encouraging them to go into underserved areas, support for primary care specialties. That there are a number of different avenues trying to help. I am a primary care physician, but my love has always been geriatrics, and people think that that's a paid-for area because of Medicare being accessible, but healthcare goes beyond just the doctors and the hospitals, and there are huge unmet needs in long-term care. And some of the things within the health reform that the geriatric folks, end-of-life folks are excited about it. There are some programs to try to enhance those training areas as well.
We've got another question from someone in our audience, Dixie Thompson, and would you please stand up? And she maybe is approaching it from another point of view. She's looking at places where people could go to free programs that can't miss work or school, but maybe not necessarily medical doctors. Or please explain what you're saying.
Well, I'm a women's health nurse practitioner, and I have opened the Pensacola Downtown Health Clinic, currently providing women's health services at low cost for both insured and uninsured. My area of interest is in addressing that group of people who kind of fall into the cracks, the working people, the students, the parents, people who have multiple jobs and cannot miss work, cannot miss school. To address that, I've got some extended hours. And Bill asked me earlier, and I'm ashamed to say I didn't know, Dr. Smith, whether Escambia Community Clinic offers extended hours or weekend hours of service.
Well, for our open access or urgent care, we're open 7 days a week from 8 until 8 on Monday through Friday, and from 8 until 6 on the weekends.
Would that include women's health services?
Certainly office GYN, yes, it would include that. But during regular hours for other procedures, that's the availability that we have.
Mm-hmm. And Dr. Jacoby, one of the things that has been raised as a potential part of the puzzle for increasing access to care has been nurse practitioner managed clinics.
Right. I love working with the nurse practitioners in the long-term care setting and with geriatric care, and I think there is a big push nationally that we look at the whole team. Dr. Pablo was talking about the team in the ER, but I think the team can help extend manpower if we find the ways to complement each other. They're looking at different levels of training. Are there ways to shorten training? Some of the med students say they're hearing rumblings, they're going to try to shorten the number of years, and I think how much they have to cram in already in that 4 years, and then they have another 3 to 7 to 10 years after that if they're going into certain specialties. But we just have to figure out how to make the most of what we have and how to encourage people to go into those fields. It's really a shame that a lot of the best minds now are choosing other professions because they just feel that the rewards are not there in medicine. My husband used to say you had to either be rewarded financially or by the pats on the back or by prestige. And in a lot of ways, medicine has lost all three of those in some fields. The money's to be made in other fields. Patients don't necessarily appreciate you like they used to. The surveys say people always think their doctor is wonderful and all the other doctors are bad, but there is something to that, and they don't have the status they might have had at one point in time, and people are looking at other types of careers.
Dr. Lanza, I wanted to talk about when they're discussing healthcare reform, one of the things they talk about people not having insurance, and it's a cause of thousands of premature deaths each year. And tell us about that. Why do we have these premature deaths when we have people without insurance? It's probably pretty obvious that they're not getting care, but how does it get to the point where they actually die?
Well, this is why they end up in the emergency department, because they haven't been receiving continuity of care from a primary care physician who picks up the early diabetes and treats it properly so they don't get to the point where they have a crisis and end up in the emergency department, or they have a cardiac, heart problem that keeps on going and going and going, and finally they end up in heart distress end up in the emergency department, and sometimes they don't make it. So it's critical that the access to continuity of care be made available somehow or other. And with the lack of physicians going into primary care, as Dr. Jacoby pointed out, that's going to be a real problem in the future.
Well, Dr. Pablo, emergency rooms open 24 hours a day, 365 days a year, right?
Correct.
Always open, always open. And when people have these problems and they come in and they should have seen a doctor a lot earlier, but they, delayed, and then you get them at 2 o'clock in the morning and they're very, very sick. What's your thoughts on that? Could it have been prevented?
A lot of what we see could have been prevented or at least mitigated with earlier intervention. I mean, the example of the diabetic's a great example. We see people with diabetes complications all the time, things like bad infections in their feet that clearly could be avoided if they just had good ongoing primary care evaluation, good control of their blood sugars. They come in acidosis, which is where the sugar gets so high that the body has an acid buildup and they can go into shock. They come in with complications from the diabetes, like peripheral nerve disease and heart attacks and all those kind of things. All of that can be mitigated and delayed to a great extent by proper ongoing care on a regular basis. Mary Tyler Moore is a great example of that. She's a diabetic, and look at her.
I wanted to,
Bill,
go ahead. Yes, sir.
I'm sorry, I started to say, we won't have true health care reform until we push more the payments that insurers and the government are making to the front end in more of that type of care.
To add to that, just preventive screenings, a lot of things could be prevented early if we start screening. In addition to which, do we have patients who put off, even when we want to do certain tests, they put that off because they don't want to have a bill. And so I've had situations where I want somebody to have a stress test and they say no, they can't have it because they don't want to owe money at the time. And when they actually call me then to have that stress test done, they're taking from the stress testing directly to the cath lab and to bypass. So people in situations where they just delay getting their care, they'll die prematurely.
David, we have a question here from the audience. They didn't want to actually stand up and say it, but the question is basically this. These people that come into emergency rooms that don't have health care, why don't you go out after them? Why don't you, do what you can to get some kind of payment from them? Is there an experience that you've seen that it's pretty hard getting blood from the stone?
Well, we do. I mean, we talk to patients, and a lot of patients who are uninsured have a conscience, and they want to pay something. And we do talk to them about what can you pay. We'll certainly take a lesser amount. We'll certainly talk to them about it. But the bottom line is, we do that, and the return is still very low in terms of what they can actually pay.
You said one time it's about 3 cents to a dollar?
About 3 to 4 cents on the dollar.
Okay. All right. I wanted to talk a little bit about, Dr. Lanza, some of the other services offered to the uninsured by the Escambia County Health Department. Free children's immunizations. That program's been there for a while, right?
The Federal Vaccine for Children's program has been very effective in getting children 95% vaccinated by 12 years of age in our county and in much of the state. It's been a very effective program. But just going back to preventive care, 97% of the healthcare dollars spent on treatment and not prevention, whereas 60 to 80% of diseases are produced by lifestyle choices. Many of those choices can be pushed in a different direction. So, attacking it from the prevention point of view, which is what public health is all about, that's what we do. You see the billboards all over the place. You see the H1N1 billboards and the radio ads, and there's going to be a TV ad coming out. Vaccination, classic for prevention. That's what we do in public health.
You also have a testing program for sexually transmitted disease, and tell us about that and how people can come in and be tested, and there's a treatment program for them, or how does that work?
Well, actually, I wanted to get in there because my staff told me to talk about EscambiaHealth.com. That's our website for the Escambia County Health Department. You go to that website, you can see all 56 of the different programs and services that we provide. But we do have a sexually transmitted disease clinic that runs 5 days a week at the health department. And if you can't afford to pay for the testing, we will bring you in and check your eligibility, and on a sliding scale, just like Escambia Community Clinics is, you could get, I don't want to say free care because nothing's free, but no charge to yourself. We do have that available. We do have HIV testing also available. We have a family planning clinic, especially for teens and women of childbearing age, that we have available at the health department that's based on a sliding scale. We have the majority of our programs are directed towards the uninsured or the underinsured.
This is another question. They didn't want to use their name, but they're talking about people with mental health problems. In this case, it's depression, and what can they be treated at clinics, and where's the best place for someone to go who doesn't have any insurance but has a mental health problem?
I'll address that one because sadly I learned that one of the outreach programs several years ago wanted to do screenings for depression, but because they weren't sure where to refer the folks they found with positive screens, they chose not to do it. And I think you can always start with your primary care physician if you're lucky enough to have one. The free clinics, we deal with a lot of people with depression, situational and otherwise. But Lakeview Center for me is our stopgap resource, as ECC is for people regardless of their ability to pay. And those types of settings use a team approach. They have people with different levels of expertise. And unfortunately, it's difficult to get into that system and get to the right person that can work with you. I had a lady in Health and Hope last week that I think had not simple depression, but a very complicated story, had tried to commit suicide 5 times, and she wanted us to take care of her. And I said, that would be like asking me to do your heart surgery, Dr. Conkle. And I said, you just really need to access care at Lakeview, and we'll still work with you and try to help you with your other problems. So we got on the phone with them, and she was told to report probably Monday about 9 o'clock was a slow time to get in the wait line and to have her copay. And I just really wonder if she got there on Monday morning. So we have systems, but they're still a challenge to use.
And I want to thank you all very much for coming out tonight and talking about treating the uninsured. Thank you very much. Thank you for joining us for this town hall meeting on treating the uninsured. For more information, you can go to our website, WSRE.org. We do have a lot of health-related services and links and that type of thing. So we'll see you next time on Inside Healthcare.